Welcome. In this video today, we're talking about a really difficult subject that has arguments on both sides, and it has merits on both sides. But what we're discussing is opioids for pain relief, and really why my clinic has decided to choose a different path. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician who helps patients understand their options for how to be able to deal with physical or mental pain, how to be able to punch it in its face, and how to be able to get back to leading the life you deserve. Today, we're talking about a topic which is incredibly difficult for patients in a lot of ways. We've touched on this in a lot of different discussions, but at the end of the day, we're referencing both sides of the argument, or at least attempting to do so. Those from advocacy groups that focus on chronic pain patients, and also guidelines for how physicians, whether they're pain physicians as described, or other traditional internal family medicine, primary care specialist physicians, and what they should do in terms of how to be able to deliver care. The article that we're utilizing in reference is this article, which was published in Pain Physician in the fourth quarter of 2023, which is basically a consensus guidelines for how to be able to deal with prescription of opioids for patients that don't have cancer. And we're using one of the more prominent pain advocacy groups, which is the National Pain Advocacy Center, and which was put forth by a lawyer who had chronic pain and also gave a TED Talk that discussed some of the limitations of how patients are being unjustly treated and how to be able to represent themselves differently. So initially, we'll start with the advocacy component, give a big picture understanding of what a lot of pain patients may experience. I'm sure this will put forth a number of different comments within the aspect of the video from our YouTube audience, and we want to hear your comments. Clearly, not one answer is going to be the right answer for everybody. That's just a plain fact of the matter. But if we can have a conversation that's reasonable, that's respectful, and find ways to be constructive with moving it forward, then I think that's something that we should do. So when we look at this one group, that's the National Pain Advocacy Center, we're going to talk about it a little bit more in depth in detail. One of the things that they publish is the current approach to pain leaves too many people suffering. What they're basically referencing is limitations of opioids for a number of patients. We'll talk about it, but just kind of jumping ahead so you can kind of identify and understand, why our practice is quote unquote a bad guy. We've decided to make a decision to stop using opioids for our patients, but there's reasons for it. And it's not meant to be limiting towards patients that we treat. And it's not meant to be punitive. And I will explain that a little bit more detail in just a second or so. But going on from the advocacy group, what they state is many clinicians receive only 9 hours of pain education, period. And that's meaning throughout medical school or post medical school, which is really difficult for a good number of patients. That the presenting chief complaint to most physicians' offices, not just pain offices, but physicians' offices, is number one, upper respiratory infection. Number two is some form of pain, whether it's back pain, whether it's abdominal pain. That piece really is limiting in a lot of medical education. It's known, but it hasn't been prioritized, and there's a number of reasons for it. Anyway, so secondly, they talk about the aspects with issues with investment in terms of patients that spending on pain research is inadequate, particularly with how prevalent it is from an incidence standpoint. And in addition, that there's breakthroughs that are constantly happening, but they're not being moved along the pipeline for patient utilization. So historically, we know that pain has undergone a rapid change and transition, and there's both what's presented in the media, and there's also what's present within the medical infrastructure and practice, which is one of the things I'm going to talk about. This next slide that's taken from that advocacy group is spot on, but there's other pieces to it that aren't always prevalent that patients understand or are given privy to, and we're going to talk about that. So what they talk about is there's been a pendulum swing. In the early 1990s, doctors were encouraged to treat pain. It was actually listed as the fifth vital sign. And in that context, what was done is that opioids were utilized aggressively to try to be able to treat pain. And then in the 2000s, what began to be postulated was that quote unquote liberal prescribing practices had contributed to addiction. Actually, this article that I referenced earlier is going to talk about how that's probably not the case, to be frank with you. But be that as it may, what they started saying is, okay, public health agencies started urging doctors to be more cautious with prescribing. And then finally, today, what we see is that health agencies are implementing strict laws and mandates, and they're limiting access in a number of different ways, both in recommendations to physicians and the like. So that pendulum swing that's discussed, right? Well, one of the things that we see is that from a physician standpoint, coming from an interventional pain fellowship, trained, done it for a number of decades now, there is a number of physicians that have no desire whatsoever in doing pain management. And the problem and the issue with that is, as an interventional pain physician, when you're trying to be able to use colleagues to help be able to look at a multidisciplinary problem. And what I mean by that is the following. So let's say you have some person who has traditional back pain, maybe secondary to arthritis. If you're talking about things that we've talked about in our videos, things like facet disease, osteophyte formation, things along those lines that we've referenced, and we can talk about at a later point in time. And they have rheumatologic issues, right? So they have traditional joint pain, but it hasn't been evaluated. So we're treating the things that fall within our scope, but when we frequently send those patients to a rheumatologist, what ends up happening is that they won't be seen because now they're under the care of a pain physician that subsequently needs no help. When historically you would treat that patient if they were only rheumatologic alone using rheumatologic methodology, things where you might use infusion therapy and other elements. But now we have to make up the difference by using opioids, which may not be as efficacious. And that's just a pure and unadulterated fact. Going further into the advocacy piece, one of the things that we see is that Americans spend about $87.6 billion, not million, billion dollars in a single year on low back pain and neck pain alone. And they state that the best treatment often combines different types of therapies, meaning multimodalities. And traditionally, those individuals who are disadvantaged and don't have the best insurance are actually left by the wayside. So that is an unadulterated fact. The fact of the matter is a good number of patients who have problems and issues, their insurance is limiting. And it traditionally funnels them to what is the most quote unquote cost-effective solution, which normally, quite frankly, is an opioid therapy that is what they're pigeonholed into, frequently without diagnostic ideas and criteria that help evaluate what the problem is so you can hopefully be able to at least diminish it, if not be able to eliminate it, but many times then causes other problems that are associated with it. So more than 50% of doctors won't see a patient who's being managed using opioids, and 81% are reluctant. And as I alluded to in that previous commentary, one of the things that we really have to kind of deal with is, so how do you provide multidisciplinary care, multimodal care, when we know that multimodal care can be able to be useful, it can be effective? So this particular reference and website states the following. So 1 to 8% become addicted with the use of opioids, meaning so it's a small number, prescription opioids, that is. Most patients who misuse opioids didn't get them from a doctor, but borrowed them. The current government and medical guidelines provide a role for opioids in pain, not managed by other means. And that's not really true, to be honest with you, because there's not really a lot of different dynamics of being able to use multimodal therapies that insurances are supporting because of the expense and costs. In most cases, opioids should not be a first-line therapy for chronic pain, but when prescribed appropriate, opioids are indispensable for some patients. I've heard that stated for my whole entire career, and I will tell you, it's not what the traditional practice is, particularly when you're seen by a pain physician. Historically, it said, oh yeah, let's go to physical therapy. And many times insurances will state that. But most of the time, physical therapy doesn't necessarily give us the result that we want. And by this time, the patient is traditionally on either tramadol, Norco, Percocet, something of the sort, which may not have been the best starting medication. We probably haven't done a genetic test to be able to evaluate it, let alone a true extensive physical exam that's respectful of the patient, doesn't make their pain worse, but helps identify areas that may have been missed with a traditional cursory MSK or neurologic examination. So now we're kind of in this pigeonhole where we made the person somewhat semi-functional, and to take and change that medication then makes it more difficult for that person to be able to live their life the best that they can right now. But be that as it may, continuing on, that most overdose deaths involve other different types of substances and using illicit substances at the same time. So as I said, it's a complicated problem. I think that the National Pain Advocacy Group has really presented some things in depth and detail. And as a matter of fact, we're going to reference another dynamic that references a full evaluation from Pain News Network that comes from Kate Nicholson, who is the founder and is the lawyer that I referenced before. And one of the things that she talked about is, as just a group, we need to advocate more broadly for the better treatment of pain, because even though we are able to stop a bad policy here or there, it's like a whack-a-mole, right? But one of the things that she really mentions as you go through this article is that my own feeling is that pain needs a rebranding. Sorry. And if we think of chronic pain as a disease, then we shouldn't we be calling it something different? We don't call depression chronic sadness, even though everyone feels sad. I really feel like there needs to be a shift in how we talk about pain and how we understand it. And there really needs to be a bigger conversation than just one modality. To that, I think we can agree. And I think that there are some things that really need to be looked at and identified as to why there are limitations, particularly in the medical community, but also from an insurance standpoint, on why pain is very difficult to be able to be treated and be able to be treated, quite frankly, fairly. So going to this article, one of the things that has been prominent in the guidelines that many physicians have been given is this context of 4 waves of opioid overdose deaths. And let's be clear, the opioid overdose deaths are not equally correlated to prescription of traditional opioid medications. It's frequently inferred, but they're not one and the same. And we're going to talk about that in just a second or so. But what has taken place is that there was a wave 1, there's a wave 2, there's a wave 3, and what is now suggested as a wave 4. So when you look at the actual aspects of the timelines of this, you can see it kind of mimics that pendulum swing that was talked about before. So early 1990s, and then you can see this construct that took place in the early 2000s, and then around 2003 or so, and then in and around the epidemic. And what we see is this aspect of really it being the utilization of any opioid, but more importantly, synthetic opioids. So things like fentanyl and illicit substances, as opposed to, if you look at this green line, commonly prescribed opioids, which kind of stay in this sort of flat line dynamic. So what are we looking at? The y-axis, again, is deaths in 100,000s of population. And what you can see over the aspect or axis is that you can see the number of years that are in place. And prescription of opioids, to an extent, have tailored down, and we'll show that in some other graphs, but you've seen these overdose deaths that have increased. Why does this matter? Because this has been a political agenda that has looked at have we utilized medications appropriately, and we've had correlations with deaths. And what we see actually from the interpretation of the data is that's probably incorrect. Going on, one of the things that we looked at is who does chronic pain seem to affect most? And the fact of the matter is that it actually is probably more prevalent within the Native American population and then subsequently the white non-Hispanic population more so than other groups. So, and particularly it's really reflected within socioeconomic status of those two groups in particular. We look at the distribution of what are the different pain problems. What we see is a primary component, if you can be able to make that out on the left-hand side, is lower extremity pain that's present, then back, then upper extremity as being the most prominent 3, and then falling off as that 4th is headache, which is not a non-challenging, is actually quite difficult to be able to treat. And there's a number of different modalities that look to be able to do that. But the first 3, that aspect of lower limb, knee, hip, ankle, back pain, and then upper extremity are probably our most prevalent issues. When we look at the construct of this paper, and in particular, this next slide, it's really interesting and it's kind of subtle. We're going to talk about this, but it's really very informative. So what this slide shows is the number of overdose deaths that has taken place. And you can see that there's an increase, but there's also a tapering off. So what you can see is that there's a difference clearly from 2016 to 2017, where they had 44,000, right? And then you see this 81,000 that's present in 2021. But you see a drop in 2022, and you can see that the rate of where it was isn't quite as great as what we had expected, particularly when you look at this. And so there's some things that this article does go into depth and detail and prose, and we're going to talk about that. When we look at prescription medications alone, historically, we've stated, oh, it's because it's a high dose or high concentration, high milligram dosage of medications. What this slide looks at is the color distribution of what MME is. And so for those of you who aren't familiar, you can see in this bottom aspect down here, it describes it, which is morphine milligram equivalents per day. In essence, what's your dosage? Historically, what we've looked at as being quote unquote appropriate are this dark blue and lighter blue, which is 50 morphine milliequivalents per day or less than that, preferably, is what has been the thoughts for most states and what they've mandated. And they've looked at patients that have been at 90 or 50 to 90 and how this breakdown has been. You can see from 2011, the reduction from those high doses to 2019 is around 70%. So the vast majority of providers have reduced this. And some of that has been accordance to the provider making that decision because they've been stigmatized by other docs saying, hey, but secondly has been by insurances as well as other entities that have said, hey, doc, you need to get this in line. Otherwise, you're going to be an outlier and there's going to be problems and issues for you. But let's come back to the patient issue, because that's really what we're talking about here today. And when we look at this graph, which has a number of different lines all over it, like it was a kid that drew on the wall with multiple different crayons, what we really have to take a look at is this bottom red line, which is opioid prescription deaths. And versus everything else, we can see that this number has been flat, right? And then you take a look at the green line, which references those last two slides that we looked at. And I know it looks like a lot, but it's basically the morphine milliequivalents per day. And from 2010 over to current day, what we can see is that it has dropped off considerably. So if our opioid prescription deaths are staying stable and we can see our morphine milliequivalents are actually decreasing, then what's causing the total overdose deaths? And that is what we talked about before. It's coming from outside of traditional prescriptions. We can see when we look at overall deaths, particularly for the age group and the group that we're looking at here, that diabetes is stable. Chronic liver disease has increased slightly. Suicides has actually increased, and lung cancer is decreasing. But what we can see is probably the greatest slope is poisonings. And in this regard, poisonings are related to illicits or substances being inappropriate. So what we see in this graph finally is that breakdown. And this line that is that area that's highlighted in blue is the line that's prescribed opioids and how it's been flat. And then you can see this yellow line, which is related to fentanyl and other illicit drugs. So there's been a number of things that have been stated common sense wise as well. If patients can't get medications like traditional opioids, then they'll just go to the street and they'll use illicit substances. But what you would expect is a seesaw effect, if that was indeed the case. Meaning, so as you decrease the areas of your morphine and milliequivalent doses, that you would then expect to see an immediate increase that would represent that slope. But they're different. The number of illicit substances are outside the scope of what we've seen for the morphine milliequivalent dosage and decreases. And so when we take a look, particularly for those people in population that seems to be most impacted, what we see is that it does segment out, particularly as you look at, remember our construct before of, we saw that Native Americans and white population is who seem to be most grossly affected. And when we look at this, what we see is that those white non-Hispanics between 50 and 54, the individuals who are most affected are those who don't have bachelor degrees, who are high school educated, and potentially have a difference in what their insurance may be, which limits them in being able to have equal and fair treatment. When we talk about this from a doctor perspective, doctors historically have said, well, we're concerned about patients that are doing doctor shopping. And so this slide represents that. It's a look where you can see on the left hand patients and on the right hand, you can see overdose deaths. You may not be able to make out the whole key and logo, but basically the darker color is patients who are basically doctor shopping. They're seeing multiple doctors and they're trying to be able to utilize that to do drug diversion and send it to other different patients and individuals. As you can kind of see, they represent about 10% of patients and 40% of deaths. But what we see of this other 60% is 40% are those who are seeing one doc with high dose, and the other 20% are those docs who are seeing only one doc and they have low dose, which to me is important, right? So if you tell me 20% of the overdose deaths are from patients that have a low dose usage and they're doing the right thing, but we're not monitoring them correctly, I feel like that's an issue that's incumbent upon physicians to figure out how do we do that better. Because if we said we had a drug, not even dealing with the aspect of opioids, but let's say we had it for cardiac or diabetes, and 20% of people on that drug were dying, no one would say that that's okay. They just wouldn't. They would say we have to do something about that. We have to do something different. The consensus statement that looks at this and kind of summarizes this is the following, is that it's contradictory, that basically overdose deaths in 2021 increased half as much as what they did in 2020. And declined modestly in 2022, if you recall, reference that green bar that showed kind of that tapering off, if you would. And it showed that an estimated 79,000 roughly Americans died from drug overdoses between January and September of 2022, and fewer than 81,000 who died during the first 9 months of 2021. But still 50% higher than pre-2020 deaths. So at the end of the day, what we see is that the aspect of prescription opioids right now are probably not the contributing cause for most of the overdose deaths. So that paper has come out with 10 summary guidelines, which has been taken up by the medical community. And as patients or those who care for patients, you probably want to know what that is because it's going to affect what your care happens to be, assuming that you fall within the criteria of individuals who need management. And although it's kind of small lines, let me kind of give you the summary of what's in place. One is that you need a comprehensive evaluation of pain, which historically is traditionally not done in most clinics. Two is that you need a physician drug monitoring program, which is a patient you probably aren't aware of, but most of the time physicians and advanced providers will actually utilize, which is provided through the pharmacy, that allows for us to be able to see what patients got what medications and what pharmacy that was present. Three is risk stratification, which many groups do, but not everyone does, that assesses, are there certain things that make you more at risk for having an overdose death? Four is using drug monitoring, which can be incredibly challenging. And although the states doing drug monitoring should always be implemented, many times insurances will push back, have patients who are at risk be more at risk for utilization, despite the urgings of the physician. Five is prior to starting opioid therapy that we should discuss risk and benefits and how to be able to establish those treatment goals. And this one is one of the things I would say is probably one of the most complex things. Because one, most of the time by the time the patient has reached a provider that is experiencing dealing with traditional pain, normally they've been exposed to an opioid at least once. Two is once you help someone be able to be somewhat functional and you've provided a medication that's given them some degree of benefit, it doesn't always work that way indefinitely. I think that can be the case for some patients, but for most patients, it doesn't. And I'm not talking about patients just becoming tolerant or dependent, but sometimes that aspect of pharmacological physical change that's placed, you have to either change the medication you're utilizing, switch it up, even though you may not get the same degree of efficacy, wait for receptors to change and see how their response is, go back to your original medication. And historically, most clinics and most providers don't do that well. But at the end of the day, it is one of the things that is probably one of the most difficult if you're using med management as the predominant treatment dynamic of being able to monitor and help patients. And then finally, you talk about the aspect of an agreement and whether medical necessity is established. And this one is really the thing that I think is one of the true difficult things to be able to make sure patients are given what it is that they need and to some extent deserve. Because medical necessity is frequently a moving goal post. It's what insurances utilize to determine whether treatment is appropriate for the patient and whether they will reimburse a physician accordingly, right? And so if another provider who's frequently not a provider who's been trained to to deal with pain. As we know, as originally stated in one of those slides, sometimes only 9 hours of training is given to most physicians unless they've pursued a fellowship. Most of the time, they will use a criteria that's present within the insurance guidelines, which weren't made by clinicians, that will say, oh, well, this is the deal. For this person, we know you've been treating them like this, but you can't treat them like this any longer. And why is that? If you're the doc, they'll say, well, because there's no medical necessity that shows this. Well, we have radiologic evidence of them having disease. That's not appropriate. Okay, we have physical assessment using oswestry or other functional scales. Not sufficient. Okay, we have chronic pain scores that show and we're able to delineate this over the course of not only months, but being able to show years. And that accordingly, they've been appropriate when we look at what their PDMP has been, what their urine toxicologies have been. Still not a fit. So one of the things that makes this incredibly challenging is when you have a goalpost that's moved for medical necessity that then pigeonholes patients into a cheaper treatment option, which frequently isn't the safest. That's when we come back to those 20% of patients that are doing the right thing, but they're still at risk and they potentially have a death. It doesn't mean that by us trying to save those patients that everyone else should suffer. As I stated before, it's a very complicated discussion. There's no doubt about it. And final, that conclusion to those guidelines is, in essence, that chronic pain opioid therapy should be provided. What they state is in low doses with appropriate adherence monitoring and understanding adverse effects with those patients with a proven medical necessity. My counter and my pushback, and one of the reasons why we've changed our practice, is that medical necessity piece is a moving goalpost, number one. Number two is not every patient is really looking to be functional, which is problematic for me personally. And I'm not saying that that's the case across the board. Let me be clear, because I know that I will get a number of insults and comments within the aspect of our video afterwards and say, oh, this doc, he doesn't support patients. He doesn't want to be an advocate for us. And that's not the case. But what I can definitely tell you is that there's a number of our patients who have felt comfortable in saying that their medication is great, but at times their pain is still an 8, a 9, a 10, and they're still not functional. And for me, that's very hard to be able to balance that out. How can our pain be well controlled, but your pain is still high and you're not functional to do stuff too? If that is indeed the case, shouldn't we be doing something different? And when we talk about being able to do something different, some of those patients aren't inclined to do that. Now, let me be clear. I have some fantastic patients who are open to being able to do that. And they're saying, hey, you know what? Help give me ideas about what else can we do differently. And we know that we're in alignment. But we know we're not in alignment with every patient, because for us, what we want to do is, stated before, give patients options and help them punch pain in the face, whether it's physical or mental, and get back to leading the life that they deserve. One of the things that we see as we looked in this article, and one of the things that we know from an experiential piece, is that pain takes little by little from that person. Sometimes when they're highly functional, and now pain is being able to kind of decrease what your energy, your activity, what you can be able to do, what you can continue working the job that actually covers your insurance, and it limits you from being able to go forward. And we have this kind of cyclical pattern of using steroids as a potential treatment option, which causes many times the actual tissue to be worse, which now makes you more dependent upon the patient, more dependent upon the physician, or more dependent upon doing different treatments. And I feel like it's backwards, but we won't talk about it. Two is that we prescribe an opioid that sometimes for a certain subset of population causes opioid-induced hyperalgesia, which is this increase in pain due to the actual medication. But many times patients feel like we're basically BSing them and saying, oh, that this is the case. And they think that there's no such degree of a physiological or pharmacological response. Though it's been defined in the literature. It's not there for everyone. And it's not a high component, maybe 10% of the population. But if you're that 10%, we really need to be able to do something different. And then three is just moving goalposts of medical necessity. So one of the things that we've looked at and we think is the path that's a fit for us, not for everyone, is to say, how can we really be able to characterize and quantify pain better? And that's the thing that I think makes sense. When you talk about cardiology and you say to someone, hey, I have a stenosis that's present within my cardiac vessel, that's 70%. Okay, you should intervene. 90%, now you should intervene. Now we have a quantifiable component that allows For insurances to say, oh, I don't think it's a necessity. Yes, it is, because it's 90%. And you know the literature shows that that is indeed the case. It's representative of it. Or diabetes. You have a hemoglobin A1C or blood glucose sugar that shows an amount, and it looks at, okay, this is the amount. So then now we need to treat with this indication, or we need to treat with that indication, right? But pain has been very difficult to be able to be representative. One, because it's broad in nature in terms of the different body parts, as we referenced before. But two, is there's no way to be able to equate what this person's quote unquote subjective feeling is with what their actual pain has been. But where we're starting to lean into, and what our office is looking at differently, is can we look at different mediators that are present within the blood? Can we be able to use biomarkers that are present within the EEG to say this is indicative of what pain happens to be? And even if we have to go outside the scope of traditional insurance dynamics to say, okay, let me prove to you, patient, this is where you started. These are the reasons why you have these different issues. So then subsequently, we can then be able to say, what has our treatment done? Did it work, or was it worth diddly? And now why do we pivot to do something differently? That's the reason why our practice is pivoting and why we're doing some things a little bit differently. Do we think that our current utilization of resources for being able to help patients are the best? By no means. Will we always try to be able to give a fair account of how we think patients are not always getting the best options presented to them? Certainly. Hopefully this video was of value to you. I'm sure that it actually sparked a number of different responses, feelings, and nerves. Please put so in your comments below, and hopefully we can be able to help you understand different options for how to punch pain in the face and how to get back to leading the life you deserve. Thank you so much, and have a great day.